Okay, welcome everyone. Thank you for joining us. Today we have another installment in our COVID series, our Emerging Issues in the Coronavirus Pandemic webinar series. And today is entitled Racial Disparities in COVID-19, a very important and timely issue. We know that overwhelming evidence shows that COVID is reinforcing longstanding racial health inequities that existed prior to the pandemic. So in this webinar, we have two experts, Dr. Sharrelle Barber and Dr. Ana Martinez-Donate, who are going to update you on what is known about inequities in COVID and discuss what actions are needed to address them and to address racial inequities more generally. So first, I'm going to introduce our speakers. They're each going to present a bit on their own, and then we'll have plenty of time for Q&A and discussion at the end. Just a bit of housekeeping. I encourage you to use the Q&A to shoot us your questions. We'll be noting them and I'll be asking them in the facilitated discussion we have after each of them speak. And if I can, I'll answer your questions in the Q&A while we're going on with the webinar. So first, I'd like to introduce Dr. Sharrelle Barber. She's an assistant professor in the Department of Epidemiology and Biostatistics here at the Dornsife School of Public Health at Drexel. She's a social epidemiologist whose research focuses on the intersection of place, race, and health, focusing specifically on how neighborhood-level structural determinants of health, such as concentrated economic disinvestment and racial residential segregation, impact cardiometabolic risk factors and cardiovascular disease onset among Blacks in the southern United States and Brazil. Next, we'll be hearing from Dr. Ana Martinez-Donate, who is a professor in the Department of Community Health and Prevention, also here at Dornsife School of Public Health. Dr. Martinez-Donate's work has focused primarily on Latino immigrants and other disadvantaged populations. She applies a social ecological framework to the analysis of behavioral and social determinants of population health and the development and evaluation of community-based interventions for disease prevention and health promotion. I can't think of two better experts to join us today, and I'll be your moderator. I am Amy Carroll-Scott. I'm an associate professor, also in the Department of Community Health and Prevention, and at the Urban Health Collaborative here at Dornsife School of Public Health. And with that, Sharrelle, if you would like to share your slides and unmute.
Sure, thank you so much, Amy. So thank you so much again, Amy, and it's really great to be on with you as well as with Ana today to just really provide some updates on racial inequities in COVID-19. We had one of the first webinars in this series back in March, which seems ages ago. And so today, really going to provide some data on where we stand with regard to racial inequities in COVID-19. And then I'm going to talk about some of what we see as the fundamental drivers of these equities, particularly amongst marginalized racial groups. And then I'll end with a slide that kind of helps us think beyond this moment to what is really needed to address some of the racial inequities that exist that have been laid bare during this pandemic, but also have existed prior to this time. And so this is just data from the CDC recently compiled for different COVID-19 outcomes with regard to cases, hospitalizations, and deaths. And the overall picture here is that marginalized racial groups, specifically African Americans and Latino populations, have higher rates of cases, higher rates of hospitalizations, and higher rates of death compared to the white population. And again, this is the national picture of these inequities and really a snapshot of these inequities based on data from early fall. But these trends definitely play out in various ways across the country. I've also been relying really heavily on the data from the APM Research Lab, which has provided some of the most comprehensive data on COVID-19 inequities, particularly the death toll from COVID-19. And what we see again is if you look over time, the racial inequities have existed and persisted, and in some cases gotten wider, with Blacks indigenous populations as well as Latino populations experiencing upwards of a three times the risk of death from COVID-19. With regard to African Americans very specifically, by about mid-October, over 40,000 African Americans had died from COVID-19. And we know that these are really striking inequities that have been persistent for the pandemic, but for so many different outcomes. Additionally, one of the other trends that has been recently published by colleagues at Harvard, the Population Center, the Population Center, Dr. Mary Bassett is the lead author on this, also showed that not only are the death rates higher among marginalized racial groups, but Blacks and other marginalized racial groups are also dying at much younger ages. And I think that's really critical for us to be considering that it's, folks between the ages of 35 and 44 are dying, Blacks in particular, I think the estimates are between 7 and 9 times higher than their white counterparts in that same age strata. So again, we are seeing higher rates of deaths, but also younger ages, which again mirrors so many of the inequities that we see for a wide range of indicators of morbidity and mortality for Blacks. So this isn't new, but it's still very striking and very heartbreaking. That's for adults, but for the limited number of cases that we do, or not limited, but the cases we have among children, we're also seeing very similar patterns, with Blacks and Latinos children being more likely to die. And actually, this is data from July, and I have, this is from the CDC again, but that Blacks and Hispanic children, make up about 78% of all deaths for children. So they are a large proportion of the deaths among children are children of color. And this was a paper that was produced by published in Pediatrics. This looks at cases both by race, ethnicity, as well as by income. Again, seeing same pattern of Hispanic and non-Hispanic Black children having higher rates. Again, these data are not surprising, but they're no less striking. And I think it really gets to some of the fundamental drivers of health inequities in our country. And just to bring it locally, this is data from the city of Philadelphia. Again, trends with regard to race, ethnicity, higher rates of death, higher cases across age strata. Again, the picture is the same. We're seeing these very striking inequities. So early on in the pandemic, actually around April, I'll back up, around March, mid-March, colleagues and I from UCLA and other places began writing a commentary called Racism in the Time of COVID-19, which was published in the Interdisciplinary Association of Population Health Sciences. And that we actually began writing this blog post or this commentary prior to any data emerging on the COVID-19 inequities, because we really wanted to frame the narrative around why we would expect racial inequities to emerge in COVID-19. And so we said this very early on: while COVID-19 is indiscriminate in its transmission, its propagation within a society steeped in structural racism will undoubtedly, as we're already beginning to see, lead to disproportionate impacts among marginalized racial groups. Again, we were able to say that based on the history, based on what we know about other health outcomes, and based on the systems and structures we know that COVID-19 was going to exploit during this pandemic. And so we were pretty confident in our predictions, really put a call out early on that we need to be paying attention to these, because if we could predict what was going to happen, that there might be a way of preventing some of the suffering, some of the deaths, some of the morbidity that occurred. And I think this is a really critical conversation to continue to have. I know it's been definitely a narrative that has, I think because of a wide range of voices, has been inserted in the main discourse around this. But again, I think it's very important to continue to reinforce this narrative, because I think it helps us to think about what the necessary actions are. And so, a lot of us are saying, who've done this work, that racism really is America's real underlying pre-existing condition, that particularly for Blacks, you cannot understand what's happening with COVID-19 and other health outcomes without really paying close attention to the institution of slavery, and what that produced in terms of the systems and structures that continue to maintain racial hierarchy in this country. And that the time of slavery and segregation is still a relatively large part of our country's history compared to this, the years after the civil rights movement, when we still have so many systems and structures, as we again experienced during this pandemic, that continue to shorten and truncate the lives of Blacks, not only for the pandemic, but for so many other outcomes. And so it's important to really think about this, think about racism and articulate racism as doing a couple of things. One, operating through systems and structures, right? And operating in such a way that has put Blacks and other marginalized racial groups at higher risk of exposure, higher risk of transmission, but also having some of the underlying conditions that make mortality more likely. Some of these systems include racial capitalism, which has meant that oftentimes Black and Latino have been essential workers, and frontline workers have been exposed to the virus much more often than others, haven't had the privilege of staying at home and being isolated, et cetera. And so those are things that we have to take into consideration. We have to take into consideration our healthcare system and the biases and discrimination that occur within that system, the structures. And again, this was happening prior to the pandemic. So these are a couple of examples, and one more that I'll go into a little bit detail is residential segregation, which has created structural barriers within neighborhoods that amplify risk from COVID-19. And so I'll just really briefly, we know that segregation is really important. It helps us think of, it is one of the fundamental or most visible manifestations of structural racism, particularly in cities, instituted by racist policies, practices, and even sometimes racial terror. But it is persistent in our country, and there's no way to understand what's happening with regard to COVID without understanding this history. And in fact, the University of Richmond did this the mapping project, where they linked redlining maps to social vulnerability, which is a measure of how neighborhoods, different factors with regard to housing, transportation, and other factors that are necessary in understanding how prepared neighborhoods are in responding to emergencies, right? But they've linked redlining maps for several cities in the United States to the current day social vulnerability index in those areas. And again, there's some strong links between what has happened in the past and what is present, and what is, again, producing some of the inequities in COVID-19. And in Philadelphia, we did some analyses back in June where we were just looking at descriptive analysis in Philadelphia. And there are two areas of the city that are particularly striking in terms of this historical kind of look at how redlining started, the present day segregation, and measures of what we're calling structural susceptibility that, again, increased risk of transmission and exposure, as well as likelihood of death. So that's North Philadelphia, around the area of Temple University, where we see formerly redline community is currently still highly segregated, also has high levels of structural susceptibility. That is how overcrowded housing, conditions related to poverty, as well as transportation. And also in West Philadelphia, we're seeing, again, a similar trend historically, where formerly redlined or declining neighborhoods, also highly segregated now, and also high levels of structural susceptibility. And then when we looked at the data back in mid-May, and these inequities actually still persist, we're seeing higher rates of COVID in some of those same neighborhoods. And then overall, when we compared our most segregated neighborhoods in Philadelphia to the least segregated, seeing a twofold difference in cases. So again, making the links between racism, structural racism, and what's happening in COVID-19 is really important as we're thinking about, one, understanding why this is happening, but also what we need to be doing about it. I also just wanted to highlight that I think one of the other pieces that we need to be, pieces or structures that we need to be thinking about is the mass incarceration and the prison population and detention population. Again, another very vulnerable population, made vulnerable by the racist systems and structures that exist in this country. And we are seeing, you know, cases and deaths, you know, in these facilities. One of the, and I have a good colleague of mine who's been working on this COVID prison project where they're trying to track this. The hard thing about tracking data in prisons is that the data isn't routinely collected and not, or uniformly collected across the United States. It's been hard to, you know, track really what's going on, and especially so for detention centers. And so but I do think that it is important that we have a picture of what's happening within our incarcerated population, because I think sometimes they're forgotten. And they're also sometimes deemed isolated, but that's just not true, because we know that prisons are open populations, and the risk within prisons actually also confers a risk for communities and populations that are integrated with them. So again, I just wanted to highlight that. And finally, with regard to the pandemic's impact, we're definitely the morbidity, definitely mortality, but we also need to be thinking about other forms of impact. So this was a Pew Charitable Trust survey that was just released for the city of Philadelphia. I think one thing that's striking was the percentage of Philadelphians who know someone who has died from coronavirus. Like the fact that some people are shielded, some groups are shielded from the sheer numbers of folks, or we don't know as many people who've died. I think that's something that we need to be taking into account, and how whole communities have lost, you know, folks within their communities. And I think that's really, really critical when we think about the collective trauma even that folks in communities are experiencing because of COVID-19, because of the loss. And of course, the economic fallout from the pandemic is not equally distributed. And again, this shows up with regard to what we're seeing in terms of the racial breakdown of folks experiencing either food insecurity, not being able to pay rent, mortgage, et cetera. Those things are heavily concentrated among Blacks and Hispanics. So the pandemic itself, the health consequences are real and striking, but also the economic consequences are real and striking. And I think this is going to have some long-lasting impacts in our communities. So I put this slide because this is the CDC's kind of explanations for why these things exist: factors that increase community spread, crowded situation, close physical contact, enclosed space, duration of exposure. These are all important, but I think they're also decontextualized, right? Because what populations are more at risk of being, for example, in crowded housing conditions or having to work in crowded working conditions, et cetera, can't limit their physical contact. So again, I think it's really important that as we put out these kinds of risk factors that we contextualize them properly. And then again, also in terms of actions, wearing a mask, social distancing, hand hygiene, cleaning and disinfecting. These are all very population-based actions to reduce spread. But again, marginalized racial groups who have been impacted by these systems and structures are constrained by their context, but constrained by these systems and structures. And so as we're thinking about how to prevent disease and suffering, we've got to be thinking not only about these kind of individual level factors, but also the systems and structures that constrain them. Which moves me to kind of broadly what I think are some of the remedies, and we can talk about this more in the moderated discussion, for what we're seeing not only with the COVID-19 pandemic, but beyond this as well. So one thing is we've seen renewed urgency to declare racism as a public health crisis, which I think is really critical in this moment and beyond. And I think there's renewed interest and pushing for us to do this in such a way that actually does the work. Doesn't just make it a statement, but it actually does work to really address these systems and structures that make it hard for communities to thrive. I've seen really powerful legislation come out of the Black Lives Matter movement with the horrific murders of Breonna Taylor, George Floyd, Ahmaud Arbery, and now just here in Philadelphia, Walter Wallace, where people are challenging the police system and challenging the fact that we spend billions literally on policing and incarceration in this country, but that does not match our investment in communities and infrastructure and other factors that would be health promoting, right? And so this BREATHE Act not only addresses the system of prisons and mass incarceration, but how we actually redirect resources into the communities that need them the most. Reparations has been brought up in this moment as we're seeing the devastating impact. Dr. Mary Bassett was here at Drexel a couple of weeks ago and talked about this, and there's now a New England Journal of Medicine commentary on this, talking about reparations as a public health strategy and priority, especially given what we're seeing. The election, which we are in the middle of, and kind of political involvement. But I think that is really critical, and we've seen this with this pandemic, that we as public health researchers and practitioners, we do need to engage with the political process beyond elections, because so much of what is happening is done with policy, but I think more specifically politics. And we've got to find a way to meaningfully engage with the political infrastructure if we're really going to see the kind of change. And for Blacks and other marginalized racial groups, it hasn't really been a choice. You know, for over 400 years in this country, we've had to contend with these issues. And engaging the political process has literally been a matter of life and death. And I think we need to be thinking about how that pans out, you know, in this pandemic and beyond. And then finally, I think social movement really will get us to the kind of radical restructuring of society that we all deserve, because this pandemic really exposed who we really are as a nation, as a world, really. And it is engagement with these movements who are pushing us to a better place that I think can really get us to some of the outcomes that we need with regard to so many of these systems and structures. And so I'll end there in terms of my recommendations, and happy to take questions during the moderated session. Thank you.
Thank you so much, Sharrelle. And as Anna's bringing up her slides, for those who joined us late, just a reminder that Ana Martinez Donate is a professor in the Department of Community Health and Prevention here at Drexel Dornsife School of Public Health. And please do add any questions that you have in the Q&A. We will ask them during the discussion section.
Thank you, Amy, for the introduction, and thank you, Sharrelle. It's really, you know, heartbreaking to see the data and to reflect upon the drivers of these disparities. I am going to add a little bit more to, you know, the story, the narrative that you laid in front of us, which in a way has definitely many parallels across, you know, Black people in the US, Latinos in the US, and so many other groups that have, as you said, made vulnerable, not that they are vulnerable or disadvantaged, they have made vulnerable and disadvantaged. So I'll comment a little bit on what I think has created also, you know, the story of a perfect storm for Latinos and other minority groups in the US when it comes to COVID-19. And in case people are less familiar with some of the demographics, I think it's important to start by just describing very briefly a little bit about Latinos in the US. So they represent about 18% of the population, and they're the second largest racial or ethnic group in the country. And of course, we tend to think about states like California, Texas, Florida, New York. These are the states that have the largest Latino populations. But it's important to note that Latinos are growing, and growing faster in the South and in the Midwest compared to some of the areas where they have been established for a longer time. And as with Black Americans, Latinos are also exposed to a disproportionate share of social determinants of health that really hinder their ability to thrive and to achieve excellent health and well-being. For example, they have disproportionate rates of poverty and lower educational attainment than non-Hispanic whites, and lower rates of health insurance. In fact, this group is the one that has the highest rates of uninsurance even after the Affordable Care Act passage. And of course, they're also subject to discrimination and stigmatized, and more even so during the last 4 years with the rhetoric that we have been getting from our leaders in the political realm. So it's important to bear in mind too that 1 in 3 Latinos is foreign born, and an additional third has one or two parents who are immigrants. So we have to think about the confluence of different generations of Latinos, some of them who are recent arrivals, as well as those who are second generation but is still growing in immigrant or mixed status households. In fact, Latinos make about half of the 45 million immigrants in the US. And we need to see migration as one additional social determinant of health. In the case of Latinos in particular, being foreign born is associated with additional barriers, if you will, to health and well-being. For example, lack of proficiency in English is one important barrier, which affects an estimated 2/3 of foreign-born Latinos. A lack of a college degree or not having health insurance. Also, the way our immigration system works, we have many within the Latino community who are not able to have the same rights or access the same services because of their legal status. 2 in 3 foreign-born Latinos are not US citizens, and in fact, almost 40% are undocumented. So that creates not only limitations and barriers to access services, but also pervasive fear. Fear of being detained, fear of being deported, fear of losing somebody in your family, even if you might actually be a US citizen. So this is undermining the ability to protect for families to protect themselves and to put their attention into other things, including protecting themselves from COVID-19. So when we think about the rates of COVID-19 cases or infections, you can see here in a very simple way the disproportion. So 18% of the US population is Hispanic or Latino, yet about 28% of the cases in the US is identified as Hispanic or Latino. And this might very well be an underestimate because last time I checked, almost half of the cases reported by the CDC don't have information on race and ethnicity. And we know that certain groups might be less likely to self-report a certain ethnic or racial identity. So the numbers continue changing over time because this is an evolving situation, but by some estimates, Latinos are about 3 times more likely to get infected with COVID, as much as 5 times more likely to be hospitalized, and about twice as likely to die as a result of COVID-19. And as Sharrelle was saying, it's important to keep in mind that these disparities are not really tied to any particular characteristics of this population. It's because of the context that they are operating in, is the neighborhoods where they live, is the jobs that they have, is the social environment in which they are living their lives. And I'm gonna go on a little bit on elaborating on those drivers. But just focusing in Philadelphia, before we do that, of course, numbers have been growing. As in any other places, we have an increasing number of cases here, but there is also this disproportion when we look at rates for Latinos versus non-Hispanic whites. And that is better illustrated on this chart on the right, where you can see for the different age groups how the cases per 100,000 are clearly more elevated for any ages, particularly those 20 years and older. And the same is true for mortality rates, with very striking differences in the mortality rates, which may be ranging from 2 to 5 times more likely to die as a result of COVID for Hispanics versus non-Hispanic whites. So disproportionate impact on the population has been, of course, reported in the media, and the extent of these inequities has really provoked expressions such as that this might be the historic decimation of Latinos due to COVID-19. And we know that particular populations within the Latino communities have been even more affected by COVID-19. For example, those that are involved in the agricultural sector or in meat processing, meat packing industries, jobs that have been fundamental to keep us going during the pandemic. But have also translated into a huge toll for this community. So let's talk a little bit about some of these factors. So I've organized this into 3 different sections. The first one would be, one of the main reasons is that Latinos are more exposed to the virus. And that is so because, first of all, they're more likely to be employed in what we call frontline or essential jobs. As a result of that, they are going to be more likely to contract the infection. Also, the type of jobs that Latinos have in many cases do not come with the sick leave benefits that many of us are benefiting from. So that means that even if someone experiences symptoms or if somebody might have been exposed by other member of the household, the incentives to actually present to work are very strong, and it makes it really difficult for folks within the Latino community to really try and avoid exposures or protect themselves and their community. The inability to work remotely is also disproportionately found among Latinos. About 84% are unable to do their jobs from home, as you know, many of us, the lucky ones, have been able to be doing during these times. And many of the jobs in which Latinos have found themselves have had limited access to personal protective equipment. And that is really a shame, because we have really asked of these men and women who have been working in essential sectors, as I said before, to do so without adequate protections, and to do so while staying quiet and not really even complaining about the conditions, because you can be fired, because you can be even reported to immigration authorities. And that's the reality in which many of these members of the community live. Poverty and limited savings is another factor that has undermined the ability to stay home and protect themselves. And these are some numbers that illustrate that these factors are fairly prevalent among the community. There's also documented greater reliance on public transportation, and part of this is because many Latinos are unable to obtain driver's licenses because of their legal status. Hence, you have to rely on mass transit, and therefore increasing your exposure to COVID-19. And finally, I would mention also the residential conditions. Many Latinos live in multi-generational households, and in some cases, of course, this is going to be linked to poverty and limited savings, the ability to really afford your own house. And as Sharrelle was saying, there's also segregation and over-concentration in certain neighborhoods, which increases the risk for the entire community when a member of the community has been exposed. So that's one part of the equation in my view, and that of others who had studied the evolution of the pandemic for Latinos. The other side is that for those who get infected with COVID, the disease has more severe consequences. And this is one part of the explanation is the existence of some health conditions that are more prevalent among Latinos that we know complicate the outcomes related to COVID-19. But that's probably not as important as overall lower levels of access to health services, and the sometimes an awareness about infection because of barriers to access testing, or even after finding out that they have COVID, the inability to obtain quality treatment. And this is related to the low levels of health insurance that I mentioned earlier, with almost 20% of Latinos not having insurance. The limited savings makes it impossible for some families to afford medical costs, and leads to avoiding healthcare services altogether. There is also the fear of what would happen if I go to a hospital. Will somebody ask for my status, and will they want to know about the status of other members in my family? And all of the echo about the public charge rule, which, although right now has been suspended, and who knows for how long, hopefully that's it, but has created a lot of echo and chilling effects for community members. Language barriers, discrimination in the healthcare sector, and lack of confidence in the health system and in providers are also important barriers, as it is for those who have not been in the US for a long time, the lack of knowledge of a very complicated healthcare system. So for example, when it comes to testing, what you can see with data from Philadelphia is that although Latinos represent about 15% of the population here, they make only 6% of those who have been tested for COVID-19. So that's a simple way of seeing that there are some disparities here when it comes to accessing some of the basic services related to COVID-19. Finally, I'd like to mention also that Latinos have suffered disproportionately the impact of the overall pandemic, not just directly because of higher rates of infection, but because of some of the public health measures that we have put in place to try to control the pandemic, which have translated into huge economic, mental health, and other impacts for Latinos. And I'll go through them quickly. I want to leave time for discussion. But for economic impact, I'll just mention that as of now, we still have about 11% of Latinos who are unemployed. And it is estimated that 3 out of 5 have experienced important pay cuts. Part of the problem here has also been that many Latinos have been unable to access federal relief funds. And this is so because of the eligibility criteria. You need to have a social security number and a history of paying taxes using that social security number. Many immigrants use a tax identification number. They pay taxes, but they don't use a social security number. Therefore, they are excluded. And not only that, their spouses, which might have been using a social security number, even be US citizens, are also excluded from relief funds if one of the members in the family has a tax identification number. That's a huge problem that has left shares of the Latino community outside of this important type of relief aid. Low rates of home ownership have also created huge pressure on Latinos who have found many difficulties to keep paying their rent, or for the ones that are homeowners, their mortgages. And in many cases, we have seen food insecurity, and as many as 1 out of 3 Latinos have reported food shortages during the pandemic. Now, that is not all, right? Mental health has suffered, and it has suffered in a very particularly hard way for Latinos in the US. And worriness about these economic pressures that I was describing, the fear of becoming infected and not knowing who is going to take care of your children, because some of these families don't have other support sources here in the States. The stress of having to work and not being able to protect yourself. The lack of social support and the stress added to many of the families, which granted have been true for many families in many different racial and ethnic groups, but for Latinos and Blacks, because of the social determinants that we said before, these additional sources of stress have undermined to a very great extent the ability to keep mental health levels high. Recent survey from the CDC presented data that are very alarming, with about 41% of Latinos experiencing anxiety or depression, more than 1 out of 5 initiating or increasing substance use, and many considering even taking their lives. And this comes at a time where we already, prior to the pandemic, had very low levels of access to mental health among this community because of a variety of reasons. But now what we see is that there is even less access because to the importance of the shortage or low availability of Spanish-speaking or culturally competent providers, we had to add that many organizations that provide mental health services have had to reduce their availability of services or move to a telehealth mode, which has not worked so well for many in the community because of lack of access to internet or digital literacy. So it's compounding to the situation that we already had prior to the pandemic. Overall, this has also caused reduced access to healthcare. An estimated 3 million Latinos have lost their employed provider health insurance, and many have had to switch, the ones that might have been eligible, to public insurance programs. But this might have gone with it hasn't happened without disruption or delay of services, and in some cases, the new programs that they might have obtained do not cover as many services as the ones that they had before. And that's of course, if they're lucky and can tap into a public insurance programs, because that's not an option for everyone in the community. So as a result, an estimated 1 in 3 Latino has not received medical services that they have needed on time since the pandemic started. And domestic violence has been another area that we have seen as a growing area of concern. Domestic violence affects about 34% of Latinos, particularly Latina women, and they face unique barriers to escape or break the cycle of violence and to access services, including lack of knowledge of where to go, who can provide help. Like for mental health, we still lack enough culturally competent providers that can support families that are victims of violence. And in some cases, the lack of social support, particularly among immigrants and refugees and dependents, sometimes economic dependence or dependence from an immigration legal perspective from the perpetrators, makes it impossible for many Latinos to escape from domestic violence. There's also the fear of immigration authorities, and as I said, this administration has created and increased the fear in the community. So many victims have been very reluctant to call the police to report any incidents of violence. But COVID-19 has increased all of these issues, and by some estimates, the reports of domestic violence in some areas have increased by 35%, and that's probably an underestimate. The fact that many have had to lock down in their houses, and especially the fact that schools have been closed in many areas, has also made it difficult to detect cases of child abuse or neglect, and has created conditions for this potential abuse to take place more frequently and to go undetected. And finally, something that also complicates things is that there are important gaps in digital resources between Latinos compared to non-Hispanic whites. 1 in 10 Latino immigrant families does not have internet, and many do not use internet regularly, or they use it on their phones because they don't have broadband internet access at home, or they lack the experience with computers and don't have a high level of digital literacy. That, in addition to the low proficiency in English, places Latino at a very disadvantaged situation in a world that for the last months has switched to a digital mode for most of the things that we need. So that creates disadvantages for employment because, for example, Latinos are then less competitive for jobs that have transition or need to be done on a digital mode. Less access to resources because a lot of the organizations have shut down and all the services that they provide are done online via telehealth or internet-based services. And this creates barriers for some Latinos who don't feel comfortable with computers or don't have internet to access these services. And finally, for education. Latino parents have been very stressed and have faced particular difficulties to offer the support that their kids need during a time when education has switched to a remote mode. And we've seen reports like this where kids have had to go to parking lots to access public hotspots to do their homework on cell phones. In conclusion, to give way for our discussion, this pandemic has created a perfect storm for Latino communities, for Black communities, for many communities who were already exposed and enduring an array of social determinants, including, as Sharrelle said, structural racism and discrimination on a daily basis. And this is manifesting in greater rates of infections and hospitalizations and mortality rates, but also in more severe indirect impacts of the pandemic. As we said, greater economic impact, the risk of eviction and food insecurity, disruption in health services, mental health and substance use getting worse, an increased risk of domestic violence, and overall reduced access to quality healthcare, education, and other services. So I think it's important to keep all of these driving factors in mind and these indirect impacts in mind when we present some of the data from the epidemiological statistics, because it's easy to forget about what's behind these differential infection rates or these differential mortality rates. And I have to remind myself to try and reinforce this idea so people do not go home with the idea that there is something special or different about Latinos or Blacks, that they are getting infected more so than other communities. There's nothing magic or mysterious. There are all of these structural and social factors that are very clearly connected to the disproportionate rates that we see. So with that, I want to get it back to you, Amy, and if you want to open the discussion, I'll stop it here. Thank you.
Okay, thanks, Ana. Thank you to both of you for giving us an update on where we are now with these disparities and outlining so well these underlying root causes, these consequences. I want to start the discussion by talking about strategies for prevention or to address these disparities. And Sharrelle, I'm going to ask you first, but I'd like both of you to answer this. We need to be able to work on different levels. And so I'd love to hear your recommendations for both local health departments and, given our current context of a presidential election, national strategies for addressing these preventing and addressing these COVID racial and ethnic disparities, and really linking it to general racial and ethnic inequity work.
Absolutely. Well, I think they're definitely, and what I've tried to do as I've thought about this is think about it like, what are the things that we need to do now in the middle of this pandemic, in the middle of this emergency, and what has this forced us to think about what we need to do beyond this pandemic? And I'll start with kind of what do we do now? One of the things that I think is still very critical is testing, making sure that the communities that have lacked access to healthcare more generally have access to testing and treatment routinely, and that we can't let up on that, providing that throughout the pandemic, because again, we know that we're in this for the long haul. So how are we continuing to improve our surveillance systems and our testing within local communities? And I'm just want to highlight the work of the Black Doctors Coalition here in Philadelphia, who did a phenomenal job of stepping in even before resources were available to get testing to communities, and really stepped in where there was a need, because they wanted to see they saw a need and they filled it, right? And so I think that's a really powerful example of figuring out ways to work with communities to provide that one essential thing is testing, community-based contact tracing, and figuring out how, we're engaged with the surveillance within communities. What I'll say is there's another coalition in Pittsburgh that has formed a coalition called the Black COVID Coalition in Pittsburgh. Researchers at the University of Pittsburgh, along with community-based organizations and foundations, have really come together to do some of the kind of information dissemination, challenges to some of the and advocating for some of the resources and the policies necessary, again, to increase testing, contact tracing, all of those kinds of things. And so those are, I think, some two just very basic public health things. But I do also think that we have to be thinking about the economic relief to individuals where, there are families that literally got that $600, $1,200 check or however much, and that's now gone. And so many of those, the protections at the federal level and the kind of the stimulus package and all of those, that was gone months ago. And we're still very much in the middle of it. Really, what projections are that we may see close to 400,000 deaths by February. This pandemic isn't over, and people need relief, economic relief, and that has implications for the pandemic, right? So if we don't give folks the kind of relief they're, and the food security and things like that. And so I think at the federal level, we need to be putting pressure on our elected officials to pass another stimulus bill or economic relief bill that takes, that really provides the kind of economic relief, because so many people are hurting. I think that we need to, again, be thinking, I think those are some of the things that we can be thinking about for the pandemic, in the middle of the pandemic. And then finally, beyond, I think this really has called us to really think about, okay, so how do we do this differently? Normal was not working for us before, was killing us before, but it is really killing us now. And what are the ways we align with some of the more progressive ideas about how we provide healthcare for all, for example, how we make sure that folks have a decent job with a living wage, access to quality, affordable housing. How do we make sure that, those kinds of things are in place so that everybody can thrive? How do we invest in communities, right? The infrastructure, both the healthcare infrastructure, the public health infrastructure, economic infrastructure. What are we doing to invest in communities that have been disinvested for so long and bear the brunt of emergencies like this? I think those, and so that's going to take, I think, policies at the local, the state, and the federal level. But it is time for us to begin to, reimagine and think through what that looks like, and what some of the more, what we do as a society, how we, treat those who have been most marginalized in this country.
Yeah, I agree with Sharrelle. I think those are really important recommendations, at different levels, and some of them are important to do immediately, because and some of them might take a little longer, but it's very important to advance in that area if we want to achieve sustainable changes and to break this cycle where now is COVID-19 and is one of the health outcomes, but tomorrow it will be something else. We're repeating history here. I agree. One additional recommendation I would put out there is at the local level, I think we need to increase protections for essential workers and frontline workers, and basically for every worker, right? But there has been a shortage of personal protective equipment. We need to fix that. Public health departments need to be, I think, providing more support in that area. And I think it's also important to do training. I know many departments are working on those things, but it's important to I think, reinforce this idea, training employers and, making sure that we reduce and eliminate abusive and exploitative conditions at work, that we allow employees who are not feeling well to stay home, that employees know their rights, regardless of their status and regardless of their conditions. They know what they are entitled to do and that they are protected. I think with that, there's also the need to have a little bit more monitoring and enforcing of some of these laws that are out there to protect workers, but that often are just something on a paper that is not really enforced. Nobody really is making sure that they're put in place in the workplace. The other thing I would say, and Sharrelle mentioned the Black Doctors Coalition, I think it's really important for public health departments to be working with these communities, to have an ongoing dialogue and to listen to what's going on and what are the needs. I think here in Philadelphia, we've had a good experience working with the public health department. We created a group that we call the Latino Health Collective. And I've been very impressed with how the public health department has always had a presence in our meetings and has been very responsive to the issues that have emerged in conversations with providers and professionals from Latino serving organizations. I think it's necessary to have that ongoing dialogue because this is an evolving situation. The needs are multiplying, and we need to break silos and work in a much more coordinated manner. So listening to communities, funding community-based organizations because they're at the forefront. They know the needs and they have the trust of the members of the communities to which we need to be working with and helping, and coordinating actions with them. For example, when it comes to contact tracing, there has been some discussion about, should this be based at the public health department? Of course, there are good reasons for privacy, for all of that, but we might also very clearly see how that can create some barriers because some communities are not going to be trusting, government-based professionals that, they're not going to feel that perhaps their information is going to be safe with it, particularly during this administration, right? So trying to think about how some of this could be outsourced and relying more on community-based organizations. Finally, I would say working with community leaders. Peer-driven approaches work. They have worked for so many other health issues. And I think it's important to pursue that strategy also with COVID-19 now and rely on the strength that there is, and there is much strength in the community. At the federal level, to what, or the state level, to what Sharrelle was saying, I would add for Latino and Latino immigrants in particular, it's also really important that we stop arrests by ICE and deportations and detentions at this particular time, because that is really undermining so many public health efforts to contain COVID-19. So I think that is a priority. Relief funds, they need to be accessible regardless of status, and expanding the ability to access health insurance, basically health for all, as Sharrelle was saying, is very important. And I think perhaps COVID-19 could provide the basis for moving forward in a direction that we've been talking about for so long, and seems like it was never considered a priority. Perhaps this crisis, a silver lining might be that others might think, may see the case more clearly now for some of these strategies.
We have just a few minutes left, and I actually just want to follow up with another question to Sharrelle that's really similar to the point you made, Anna, about ICE. And I think, the co-occurring crises of police brutality and police violence against Black residents, the additional trauma in the midst of this, but possibly also opportunity. Do you want to comment on that?
Sure. I think that it has been made crystal clear with both the pandemic and police brutality that racism in all of its forms is deadly, right? And I think what has happened, with these deaths, murders really, is that it has exposed what actually has been going on for years, right? So I think that's the one thing that I'd also just interject is that, these are incidents that have been made even more, I think, traumatic because they have occurred in the middle of the COVID-19 pandemic, but these have, incidents like these have been going on for decades. And I think that what this has provided is an opportunity for us to have real dialogue about the need to really examine policing in this country, examine its roots in the system of slavery, right? And how damaging and how harmful it has been in Black populations. So I think this is an opportunity for us to think about these systems, these structures, and look at the kind of reform that so many of the grassroots organizations are calling for: defunding police, abolishing prisons, those kinds of reforms that have roots in data and strategies that we can put in place for public safety beyond this. And I think what we saw last week with Walter Wallace in West Philadelphia is just one example of how a mental health crisis became a death sentence for a resident in Philadelphia because they were seen as a threat. And I mean, it's heartbreaking, it's hard, it's intense, but I do hope it is a wake-up call for us and how we move forward on addressing these issues. And again, what I would say is we need to be looking at the folks on the ground. They've already got policy platforms, like the Breathe Act is a policy platform that we just need to get behind. It's already been drafted and written by folks who are impacted by these issues, and we need to figure out ways to get behind that. We don't need more data, we don't need more tracking. We just need to get behind these issues and push the political will to get some of these things passed, which is why the political process is so important, which is why elections are so important, which all of these things matter for if we are actually going to push forward towards the kind of racial justice that we all deserve.
Great, thank you so much, Sharrelle. And yeah, and I think that they're models like Milwaukee's blueprint for safer communities through racial justice that we can certainly follow. Well, this went by quickly, so I think we're actually out of time. We will I think be letting folks know about the recording, I believe tomorrow. You can take a look and find the recording. We'll also send it around. We do have a few upcoming speakers, Sakobi Wilson next Wednesday, and Shanita Sealy Jefferson, who Sharrelle cited earlier, is, I believe, next Friday. Am I right, Sharrelle? The 13th.
I think so. I think it's the 13th.
Sorry that I didn't have it in front of me, but thank you, Sharrelle and Anna, and thank you everyone for participating, and we will see you soon.